CNS is not involved, locally involved, and patient always become stable and there is no loss of consciousness. Whereas in case of general anesthesia, patient became unconscious, which primarily reversibly inhibit the pain sensation. The important thing is loss of pain sensation, and that is reversible one. The drugs which are reduce or loss of pain sensation with a reversible effect. Second one is primarily all these actions is only on sensation. Pain sensation, temperature sensation. What are the other sensations? Joint sensation, vibration sensation, loss of these. But primarily the pain sensation. But they doesn't have the effect on the muscles. Primarily local anesthetic doesn't have the effect on muscles. So without any motor involvement. Motor involvement only occurs when there is a nerve block. Suppose the nerve is involved in all both sensory as well as some muscles. Example is, give an example who has a sensory nerve innervation as well as some muscle innervation. Radial nerve, very good. So if we block this radial nerve, what happens? Not only it reduces the sensation which is distributed in the radial part, as well as they also weakening the muscles involved in. So only when we use local anesthetic as a nerve block, they can involve the muscles. On the other hand, primarily local anesthetic only reduce pain sensation and other sensation, and that is also reversibly without any effect of consciousness. Where the first local anesthetic is cocaine. This is developed in 1860 by the scientist Albert Niemann. So cocaine is one of the first local anesthetics, and this involves loss of taste sensation when it is developed. The different drugs. What are the different local anesthetics? We can broadly classify it on amide and ester group. In the ester group, it is cocaine, procaine, chlorprocaine. Chlorprocaine is important because of H2. It is the shortest acting local anesthetic. Tetracaine and benzocaine. These are the ester group. Another one is amide group of drug. One of the most commonly used local anesthetics is lignocaine, prilocaine, bupivacaine. Dibucaine is important because it is one of the longest acting local anesthetic. So most commonly used local anesthetic is lignocaine, shortest acting chlorprocaine, and longest acting dibucaine. So there are two groups of local anesthetics, amide and ester. Among them, cocaine, procaine, chlorprocaine. Chlorprocaine important because it is the shortest acting. These are the all ester group, whereas amide group contains lignocaine, dibucaine, bupivacaine, prilocaine. All these are amide group of drugs. There are three toxicity or ADRs are there along with this local anesthetic. One is hypersensitive reactions. It's more commonly present as an allergic dermatitis to as a asthmatic attack. So range is from the skin allergy to the life-threatening condition. It is important to have a different from its toxicity. Toxicity of local anesthetic is different from the allergy. What is the difference between toxic adverse effect and allergic adverse effect? What are the different types of ADRs? C, D, E. A for augmented. That means toxicity. That means we increase dose, they produce toxicity. B is bizarre. Bizarre means not depending upon the dose. The allergic one is the augmented or bizarre. It is a bizarre one. And toxicity. Allergic one is bizarre and toxicity is, that means it is with the increasing dose. That is augmented type of ADS. Another thing is that most of these, other than cocaine, all these local anesthetics have a vasodilatory property. It has a vasodilatory property. So what happens if we use it along with some vasoconstrictor? Name some vasoconstrictor, adrenaline. So if we use lignocaine or other local anesthetic along with adrenaline or vasoconstrictor, what happens? If there is a vasoconstriction, number one, the systemic absorption will be less. So in the local side, there will be prolonged action. So systemic toxicity is reduced, whereas duration of local anesthetics will be increased when it used along with vasoconstrictor. Clear? So that can also produce some side effect. So commonly A star group of drug produce more side effects, allergic effects, not toxicity. Allergic effects are much more with A star, and methyl paraben is the main component for their toxicity. So amide and ester এর মধ্যে more allergic or bizarre type of side effect is with the ester one, and the main toxic agent is methyl paraben. It is para-amino benzoic acid PABA group of component. Whereas when it used along with catecholamines, that means adrenaline, sulfide added with these agents, catecholamines, and this sulfide can produce some allergic reaction. So that there are two components. Sulfide is an allergic component when it is used along with adrenaline, and PABA components are the primarily the agent produce allergic toxicity in ester group. Clear? So when we only use ester group of drug, give some example. What is the name one drug that local anesthetic from the ester group? Cocaine, chloroprocaine, only used without any adrenaline or catecholamines. The toxic agent will be primarily PABA group. When it is used with catecholamines, it can be PABA or sulfide. When amide group of drug used along with catecholamine, the main allergic effect is due to sulfide, because primarily sulfide, when it is along with the amide, catecholamine along with the amide, if it is produce some allergic side effect, then the major component will be primarily sulfide. But in case of ester, they can be sulfide or PABA group of metabolites. Clear up to this? Allergic reaction. This is the allergic reaction. And side effect of lignocaine seen with increasing dose. Increasing dose means it is toxic effect, augmented side effect. Augmented side effect are drowsiness, tinnitus, dizziness, tweaking, cardiovascular depression. It can cause seizure, coma. That means they can affect CNS and cardiovascular, and that can lead to death if it is toxic effect. So there are two different type of adverse reaction along with local anesthetic. One is allergic type of, blizzard type of, and another one is due to the augmentation or increased dose. If it is increased dose, it causes cardiac or CNS depression and lead to death. Allergic, that can be from the allergic dermatitis, up to the bronchospasm or laryngeal edema or bronchial asthma. Clear? In this allergic type, there may be two components involved. One is metabolite of ester group of drug or sulfide, which is present in the when it is used along with the catecholamines or adrenals. Clear? Allergic and toxic effect. In hypersensitivity reaction, sulfide, methyl paraben and ester LS. And whereas toxicities is glycine xylidide or methyl monoethyl xylene iodide is the main positive component of this toxicity. Toxicity, the side toxicity represent with PDA represent করবে either CNS or CVS, and there will be dizziness, vertigo. All these are the primary symptoms of CNS involvement. So mechanism of action, it is all these local anesthetics are weak base. They penetrate the action and key form penetrate করতে পারে unionized form of local anesthetics penetrate the action. But it is a local base. If we give some bicarbonate, did it make much more easier to penetrate or less easier to penetrate? More easier. Why? Basic drug, basic environment, that it will be much more amount of local anesthetic will be unionized form, and unionized form is easier to penetrate the action. So another explain why we use bicarbonate along with local anesthetic. কি করবে যদি bicarbonate দেয়, it make an environment where there will be much more amount of unionized local anesthetic, which is easier to penetrate the action. And there, what happens? There will be some sodium gate, and they block the sodium gate in an inactive state. If we go see this, there are one is inner gate and one is activation gate. So in case of resting or closed state, what happens? The activation gate is blocked, whereas inner gate is open. Local anesthetic binds with the inner gate and they inhibit or inactive a block state. So even there is the activation gate is open, there will be less amount of sodium comes inside the action. So action of local anesthetic or mechanism of action, first it penetrates the action and they blocks the sodium channel, primarily voltage gated sodium channel in their inner gate and make it inactivated or blocked. Clear? There are two gates, one is activation gate and another inactivation gate. They block the bind with the inner inactivation gate and block that even when there is a opening in the activation gate. So there is a less amount of sodium able to come inside the cytoplasm or action. What happens if there is a less amount of sodium? Next step কি হবে? They are unable to produce any action potential. So nerve impulse will be less. Clear এটা এই পর্যন্ত মেকানিজম অফ অ্যাকশন ফার্স্ট হচ্ছে এখানে একটা এক্সপ্লেন হয়ে আসবে কি সেটা why we use bicarbonate along with local anesthetics. Why? Because it makes the environment so that unionized form of local anesthetics is much more, and the unionized form is easily cross the membrane and go into the axonal cytoplasm. After going into the axonal cytoplasm, they act in a voltage gated sodium channel. They bind with the inactivation inner gate and prevent sodium influx even when there is a opening in the activation gate. Clear? If there is no sodium inside the cytoplasm, there will be reduced action potential. So there is a less amount of nerve conduction will be there. As there is a less amount of nerve conduction, there will be less sensation. Clear? Mechanism of action of local anesthetics. Already discussed by bicarbonate given. Now amide and ester. Ester are they produce power and produce allergic reaction. It is the most important thing for the clinical use. Now stability. Ester are less stable. They are slow onset, and they rapidly metabolize by sodium pseudocholinesterase. Whereas amides metabolize in liver. They act by the moderate onset is faster than ester. They produce more commonly toxic effect than the allergic effect. Toxic effect are like, what are the toxic effect? CNS involvement and CVS involvement. Whereas allergic reactions are much more with the ester drugs. They are more stable. Amides are more stable, early onset, and they metabolize in the liver. So their duration is more than the ester. Ester metabolized by the cholinesterase present in the plasma. Lignocaine is one of the most commonly used local anesthetics. They absorb from the mucous membrane as well as damaged skin. But their absorption in unbroken skin is not that good. So absorption when it spray in the mucous membrane or broken skin is very good. Now lignocaine not only used in local space, they can also given in an injection. If it is given in an injection, absorption is very good. And if it is given in intravenously, there is a phase called redistribution. What is the difference between distribution and redistribution? What is redistribution? So when we give some very lipid soluble drug, what happens? They primarily go into those organs where there is a well perfused or paste perfused organ. They primarily go there, and their action starts there. After that, there will be an equilibrium between that organ and blood. So from the suppose lipid like CNS, when distributed from CNS now, the lignocaine comes into the blood, and they distributed other like fat and muscles and liver. So the action of the lignocaine in the CNS can be terminated due to the distribution rather than elimination or metabolism. Is it clear? So how the action of a drug? Primarily primarily stop or reduce. How? Either metabolism or excretion. Now it is another example. If it is a very lipid friendly drug, they given in an intravenous dose. What happens? They primarily go into the organ which is lipid, well perfused. So what happens? This action of this drug starts in that organ. That means primarily CNS. CNS is most perfused organ, one of the most perfused heart. They go into the CNS and start their action. Now what happened? So from the brain to the blood. First, then what happened? The concentration of the lignocaine inside the brain will be reduced. Clear how it happened? We give a intravenous drug. It goes highest dose to the organ which is well perfused. So what happened? From the blood, highest concentration, well perfused organ, they are redistributed. First they go into the CNS and there will be a action in the CNS. Clear? After that, the other organs there is very less amount of drug. So what happened? Now there will be a stage within 1 to 2 minutes when the concentration of the drug in case of lignocaine or some IV anesthetics, then the CNS concentration is higher than the blood concentration. Clear? Now what happened? It will be come out from the CNS. By come out from the CNS, they are redistributed from the brain to the other organs through the systemic circulation. Clear? So their action in the CNS is terminated not due to the metabolism or excretion, but due to the redistribution. It happens in lipid soluble drugs like some lignocaines and more commonly it is explained in the general intravenous anesthetic like thiopentane sodium. We give the drug, go into the CNS, they depress the CNS. Now the concentration of the drug is more in the CNS than the blood. So what happens? From the CNS, drug is coming out to the systemic circulation, and that leads to, that can lead to termination of this action of this drug. Commonly, termination of the drug is due to what? Metabolism or excretion. But in this situation, there will be what happens? The termination of this action of this drug is due to redistribution. First distribute হয়েছিল, এখন আবার সেখান থেকে বেরিয়ে এসে আদার অর্গানে less perfused organe redistribute হলো. So action of this drug redistributed. আসবে না গো? Bupivacaine. Bupivacaine, it is a potent but slow onset. It is a slow onset drug. Takes 4 to 10 minutes. Duration is high, long duration. 1.5 hours to 9 hours, 8.5 hours, around 9 hours, their action occurs. It is used for painless delivery. If it is given, what happens? They reduce the pain. In case of cervical block, they reduce the pain, but it doesn't involve the motor action. That means the muscle of the uterus can produce the contraction without having the pain felt by the mother. পেনটা যে হ্যাঁ সেন্সরি নার্ভকে ইনহিবিট করছে সেই ইম্পালসটা কিন্তু উইদাউট এফেক্টিং এনিথিং ইন দা মোটর কম্পোনেন্ট Most of the local anesthetics are like that. So there will be contraction in the uterine muscles without feeling that pain. That can produce some painless delivery. Bupivacaine is primarily used in the infiltration anesthesia. Infiltration anesthesia like this, they can produce painless labor. So what are the different types of local anesthetic use? Surface anesthesia. Surface anesthesia means surface anesthesia, spray or ointment. Even Nuken gel, you use Nuken gel in gastritis, that also causes surface anesthesia, surface of the skin and mucous membrane. Followed by infiltration anesthesia. Infiltration anesthesia means subcutaneous or intercostal muscles, like when you going for aspiration of this pleural effusion or introduce a intercostal drainage, you have to anesthetize that portion. In that case, if we only anesthetize the skin, it is difficult, it is painful. So we have to infiltrate this local anesthetics, not only the skin but subcutaneous and muscle layer, so that there will be less pain. That is the infiltration anesthesia. Next is nerve block. Blocking a specific nerve. Blocking a specific nerve, much more in case of orthopedics and some obstetrics, they use blocking some specific nerve. Sometimes this nerve is only sensory nerve. Sometimes if we block a motor or the nerve which involved in both sensory and motor, they can also reduce the motor tone also for the muscles supplied by that nerve. Depending upon the nerve, that nerve which we infiltrate or nerve block is there. If it is only sensory, the sensory loss will be there. If it is only motor, there will be reduced motor action of those muscles which is supplied by the nerve. If it is mixed, both sensory and motor, they reduce both sensory and motor depending upon the nerve. That nerve supplies which muscle and which surface, depending upon that, they reduce the pain and motor. Then intravascular or regional bias block. Here a specific, suppose upper limb, all these nerve of upper limb, selecting that only for the hand, only for the arm, or only for the forearm, depending upon that, involving that bias block primarily given by intravenous route. Then spinal anesthesia and epidural anesthesia. You have to understand spinal anesthesia and epidural anesthesia. Why important? Why important? Because in this case also, we didn't use any general anesthetics. We used local anesthetics to produce spinal anesthesia or epidural anesthesia. Nowadays, most of these cesarean sections, they are not going for the general anesthesia. They go for the spinal anesthesia. Spinal anesthesia, which drug is used? Local anesthetic drugs are used, not general anesthetic. What is the basic difference between the local anesthetics and the general anesthetics? Key difference. কোথায় ইনভলভ, সাইট অফ অ্যাকশন কোথায়? জেনারেল সিএনএস, এই সিএনএস ইনভলভ হবে তখনই কি হবে? রেসপিরেটরি সেন্টার আছে, সিবিএস সেন্টার আছে, সেগুলো ডিপ্রেস হবে। আর তার মানে কি হবে? তোমাকে একটা আইদার ভেন্টিলেটরি সাপোর্ট দিতে হবে, তোমার বিপি কমতে পারে বাড়তে পারে, সেটা তোমার মনিটর করতে। মনিটরিং ইজ মাচ মোর। And another thing is that patient became unconscious. So there should be a recovery from the unconscious to conscious. Here, patient became conscious throughout the procedure, and as it doesn't involve the CNS, there is a less chance compared to the general anesthetics to involvement of the respiratory center, cardiovascular center. All these are less chance to involve. Clear? এই পর্যন্ত একটা কনসাসনেস হবে, আর একটা হচ্ছে যে যেহেতু সিএনএস ইনভলভ হবে, যে তাহলে কি হবে, রেসপিরেটরি সেন্টারগুলো ডিপ্রেস হবে, সেহেতু সিভিএস সেন্টার ডিপ্রেস হবে। তার মানে তোমাকে there will be a mechanical ventilator, you have to go for the intravenous, they may require some vasoconstrictor, BP ফল করতে পারে, হার্ট রেট ইনক্রিজ ডিক্রিজ করতে পারে, সেগুলো তোমাকে অনেক বেশি মেইনটেইন করতে হবে, মনিটর করতে হবে। In case of spinal or epidural anesthesia, what happened? They involve CNS, or spinal cord, but not involve the brain. So the respiratory center and CVS center will be not involved. So monitoring will be much more less, and patient is conscious throughout the procedure. Topical application of the local anesthetics to the mucous membrane as well as ablative skin. Lignocaine commonly used in ear, nose, eye, mouth and pharynx. In case of proctoscopy, catheterization and rectal examination, commonly used are lignocaine. It is a surface anesthesia topical application. Now what happened? Lignocaine is not very good penetration in case of intact skin. Then we require some eutactic mixture of 2.5% of prilocaine and 2.5% of lignocaine. It becomes a eutactic mixture, and what happened? The individual melting point will be reduced, so it is easier to penetrate. It is called eutactic mixture of prilocaine and lignocaine. They are commonly used in case of intact skin. So why we prefer eutactic mixture or mixture of prilocaine and lignocaine in case of unbroken skin, because it makes this, after mixing 2.5% of lignocaine and 2.5% of prilocaine, their melting point will reduce, and it's easier to penetrate the intact membrane. So it is called eutactic mixture. Another example is Nucaine gel we use in case of peptic ulcer. It is also a local anesthetic that reduce the pain produced by the gastric ulcer. It is not a H2 blocker, antacid or proton pump inhibitor. Their action, they are local anesthetics. They just reduce the pain sensation in case of gastric ulcer. So in surface anesthesia, the important thing, most of the mucous membrane and broken skin, lignocaine. Eutactic mixture of prilocaine and lignocaine in case of unbroken skin. And there is another example of surface anesthesia is Nucaine gel used in gastric ulcer. Spinal anesthesia primarily used in orthopedics procedure and in case of gynecological surgery. What is the complication of spinal anesthesia? They can produce hypotension intraoperatively, and there will be a post-operative headache that causes due to the dural puncture. So post-dural puncture headache. These are the two most important side effects for spinal anesthesia. They can produce hypotension, but it is much less compared to the general anesthesia. These complications. In which clinical situation which surgeries is preferred? Orthopedics and gynecological surgeries. This is the procedure. You will go into your ICU or ward, and there is a procedure called lumbar puncture. Have you ever done that or seen to done that? Never done. It is a similar procedure. The thing is that you have to introduce a needle. It is called spinal needle, and the first target is that it is a well placed or not. In case of spinal anesthesia, some CSF come out. If it is investigatory purpose, we send this CSF for the study, and in case of anesthesia, spinal anesthesia, we confirm that if there is a CSF coming out, needle is well placed, and we give this drug in that space. So the first portion of this coming out can be used as a lumbar puncture for the diagnostic purpose. As a procedure, we introduce this local anesthetics in case of spinal anesthesia. These are all these procedures. So what happened? In case of spinal, we breach that dura. In case of epidural, we doesn't breach that dura. So what happens? What is the difference between the epidural and spinal anesthesia? In case of spinal anesthesia, it is only below the L2 L3, whereas epidural anesthesia can be sacral, lumbar, thoracic, cervical. Epidural one. Injection site in case of spinal is subarachnoid space. Epidural, from its name, it is epidural position. The site of action. The first thing is the site of injection. Injection site is different, but the action site is similar. It is subarachnoid space where the nerves and spinal cord are there. The site of action is same, but injection site are different. In case of spinal, it is subarachnoid. In case of epidural, it is in the epidural space. Because already we penetrate the dura, it requires less amount of drug in case of spinal anesthesia. Whereas in epidural, it is large. Epidural starts slow, onset of action, and spinal anesthesia is early or quick. Motor block is more prominent in case of spinal anesthesia. Moderate or less compared to spinal in case of epidural anesthesia. That the subarachnoid space, if we give this drug, we require less amount, but they can produce cardiac arrest and postdural headache. Whereas epidural, it can become a total spinal anesthesia, and another side effect is the epidural hematoma. So difference is the spinal requires less amount of drug, they are more potent, early onset, whereas epidural is require larger amount, less potent than spinal, and less inhibition of this motor component. And where this drug given? Epidural, by its name it is very easy, it is epidural space. In case of spinal, you have to remember, it is not the spinal space, it is the subarachnoid space. But the action of both these drugs are in the subarachnoid space. Clear? Epidural, spinal. আর স্পাইনাল দিতে গেলে একটা স্পেসিফিক L2 নিচে দিতে হবে। আর epidural we can give cervical, thoracic, lumbar, sacral, we can give them. Now, depending upon the diameter, which are more susceptible. Small diameter are more susceptible by the local anesthetic than the larger diameter. If we go functional term, autonomic is earliest, followed by sensory and motor. Autonomic followed by sensory and motor. And if we go for the fiber type, see that mediated pain and small myelinated A lambda fiber are earlier involved. They reduce fast compared to the A gamma, beta and alpha fibers. They mediated primarily postural, touch and pressure, whereas C transmitted the pain and A alpha mediated the temperature. So if we go for the sensation, first sensation to go not the pain but the temperature, and among the temperature cold before the heat hot temperature. The first temperature followed by pain, then touch, then deep sensation, deep pressure, and lastly proprioception. These are the serial to reduce the sensation. First is not the pain, but the temperature. Among the temperature, cold temperature is more than earlier than the hot heat temperature. Then pain, then touch, then deep pressure, then proprioception. All local anesthetics are vasodilator except cocaine. All for explain why for MCQs. All local anesthetics are vasodilator except cocaine. All local anesthetics are they reduce blood pressure. Only one increase the blood pressure, that is cocaine. Cocaine should never be given intravenously. This is the only ester that not metabolized by the pseudocholinesterase. They metabolize in the liver. Commonly, which group of drug metabolized in liver? Amide group. Lignocaine, bupivacaine, all these are amide group of drugs metabolized in liver. Ester group of drugs metabolized in the serum by pseudocholinesterase, except cocaine. Cocaine, all the exception, that means they are vasoconstrictor, they increase BP, they shouldn't give it intravenously, they doesn't require adrenaline. Why? All others are vasodilators except cocaine, whereas cocaine itself has a property of vasoconstriction. So they doesn't require adrenaline or other catecholamine to increase its effect. Dilucane is the most potent, longest acting and most toxic, whereas chlorprocaine is the bupivacaine is the best drug for the regional block. For regional block, bupivacaine is preferred, lignocaine preferred for the surface anesthesia. Chlorprocaine is the shortest. Which sensation blocks first? Temperature, and if it is more specific, cold. Lignocaine or oxygentin is used to anesthetize the gastric mucosa. Lignocaine, mucin gel or oxygentin is for the local anesthetic effect in the gas. Because why it is important than the other? Because it remains unchanged even in the acidic medium. Why it is important for bicarbonate? Bicarbonate given they make that environment, so there will be much more amount of unionized local anesthetics, and they are easily penetrable to the action. Eutactic mixture কি হবে? Unbroken skin and topical application. কি থাকে তাতে? Prilocaine and lignocaine কত percent? 2.5%. Why it is important? Why it is? They reduce the melting point for both of these lignocaine and prilocaine. Local anesthetic binds more tightly and more stabilized in which state? Inactivated state of sodium channel. Inactivated state. MCQ all these are. Not in the active or restricted or also. is more important in activated state. Adrenaline, why it is important? It is come as a local, explain why or as the MCQ. It decrease rate of absorption. As they decrease rate of absorption, the systemic toxicity will be less. The key point. And that increase as there is a much more amount of the local anesthetic in the site of action, there will be duration of action will be increase. তাহলে এই কোড এমসিকিউটা এলে এরকম ভাবে আসবে না, এক্সেপ্ট দিয়ে আসলে তখন আর তোমাদের ক্ষেত্রে তো তিনটে ঠিক থাকবে না, একটা ঠিক থাকবে, তাই এলে এক্সেপ্ট দিয়ে আসবে। আর এক্সপ্লেন হোয়াই এর জন্য কি কি হবে? ফার্স্ট ওয়ান, increase of duration of action, decrease systemic toxicity due to the decreased rate of absorption. ঠিক আছে?